Power and purpose personified, walking towards justice, fighting for freedom. This is Speaking Now, empowering the next generation to know how to live with confidence and precision, to move with mastery and meaning. This is a spirit that is free, traveling one coast to the next, escaping the comforts of home. This is finding new friends and exploring the warrior within to destinations amazing, to destinations unknown. This is what it means to keep pounding, to cheer for the home team without hesitation. This is love and life, success and sacrifice. This is Yolanda Trotman, and this is The Conversation.
Good evening, good evening, good evening, everyone. Happy hump day to you. Welcome, welcome, welcome to The Conversation. I am your host, Yolanda Trotman. And listen, as with every show is incredibly important as far as the topics that we cover. But this one tonight is very much driven by your questions that you ask as audience members, because we are going to be talking about the state of your health. With everything that we're seeing in the news as far as COVID, with everything we're not hearing in terms of key issues relating to women's health and men's health, we're going to be talking about all of that tonight. So before we get into any of that, just a few things. Just definitely make sure if you have questions, whether you're catching us on the YouTube feed or if you're joining us live from Facebook, make sure you drop your questions in the comments, because we will see them and we will absolutely get to as many questions as we can. So again, welcome to The Conversation. Of course, I'm your host, Yolanda Trotman. If you have not already done so, make sure that you subscribe to the YouTube channel. Very easy to find. Just simply type in The Conversation with Yolanda Trotman. The YouTube channel comes up, obviously, with all of our old episodes. Our upcoming live streams are always posted there. So make sure that you subscribe at the YouTube channel. If you've not already done so, follow the Instagram page and the Facebook page at The Convo Pod Show. Make sure that you do that there. If you haven't already done so, also check out the website at theconvopodshow.com, because all of the show episodes from seasons 1, 2, and 3 are all in one place on the website. Some things are coming in the future. If you've not already done so, also subscribe to the newsletter, because there's going to be some best of clips and some mini combos that will be shared specifically with subscribers of the channel as we continue to grow our audience. So welcome tonight. Send us a wave or a heart, drop it in the comments. Let us know where you are watching from. And if you're just tuning in, or if you didn't catch us at the very beginning, at the top of the hour, we are taking your comments and your questions live. So definitely, if you have questions for our guest, Dr. Washington, make sure that you put them in the comments. So we are talking tonight, like I said, about the state of your health. And obviously, a lot of what we're talking about and what some of the preliminary questions I got from some of you were dealing specifically with COVID, especially if you caught the news today. There's a big issue that's going on with the FDA in terms of what's going to be happening just later this week on Friday, talking about the COVID vaccine booster. Obviously, some of the issues regarding the vaccination as it relates to younger children. We're talking about all of that tonight. And I'm so excited about my guest. If you caught previous episodes of The Conversation, he was with us back in April when we did the COVID, the 1 year later episode. We talked about the state of COVID, and we had COVID survivors, long haulers, if you will. So definitely go back and check out that episode. But I wanted to have him on the show one-on-one tonight, specifically to deal with very specific issues, not just relating to COVID, but also main issues regarding men's health, women's health. We're going to be talking about how do you advocate for yourself in a healthcare setting, which is particularly important, and also healthcare disparities as it relates to communities of color. So let's get to it. My guest is none other than Dr. Raynard Washington. He is currently the deputy health director from here for Mecklenburg County. He is getting ready to be the big kahuna. So excited! I get so excited whenever I talk about him in that role, because he's going to be the director of public health here in Mecklenburg County at the end of the year, taking over from our current public health director, who is going to be retiring after many years of service. But what I found most exciting about him when I first had my initial conversations with him is that he will talk plain. He keeps it real, and that's so important in this space that we're in, as far as medicine and as far as healthcare that we're separating facts from fiction. So he served as the chief epidemiologist for the city of Philadelphia. He is a proud University of Pittsburgh graduate, which, as am I. He received his undergraduate and his graduate degree from the University of Pittsburgh. So without further ado, like I said, drop your questions in the comments. Welcome to the show, none other than Dr. Washington. How you doing, sir?
I'm great. How are you? Great to be back with you.
Yes, it's so awesome to have you back on the show for sure. And we got some time because we were trying to get a lot of information out in a short amount of time. So I'm glad to have you back so that we can really have a more in-depth conversation, especially tackling some of the questions that people have. So if you're just tuning in, make sure you share this broadcast, drop your questions in the comments, and let us know where you're watching from. So let's get to the big issue. So of course, on the news today, if you caught the news, the big issue is what in the world is going on with this COVID vaccine booster? I want to get into that first, but we really need to have a real plain conversation in terms of what the numbers are, what it looks like on the local level, and then look at it broader on the national level, because you are an epidemiologist and some people don't know what that means. So give us a little bit of background and why that particular field for you.
Yeah, so I'm an epidemiologist by training, which essentially we are folks who like to study, trace, respond to, try to prevent and epidemics. And so what we train for in school really is how do you understand who's sick and who's healthy, and try to understand what help the people who are healthy be more healthy and what caused the folks who are sick be sick, and how do you address those factors that cause illness. And so most of our work really looks at sort of populations of people. We look at a lot of data. There's a lot of statistics, also a lot of biology, and really a lot of public health practice to understand how do you implement measures in a community to prevent an illness. And that goes for infectious diseases like COVID, but also for chronic diseases like diabetes and hypertension, and also for other things like injuries, like car accidents and, homicides even. So our work really spans across the spectrum.
So what's the difference between what's the difference between an epidemic and a pandemic for people who don't know?
Yeah, great question. So an epidemic is basically a spike of a number of cases of some kind of illness in a short period of time within a defined geographic area. A pandemic is basically a large epidemic that crosses multiple countries. So the pan part of it basically means that it not just impacts one country, it's impacting multiple countries. So for example, COVID-19 became a pandemic when it no longer was just impacting Wuhan, and it started to travel across multiple continents. And that's the difference.
And so what attracted you to that particular field of epidemiology?
Yeah, so I'm not really an infectious disease epidemiologist. I'm sort of a generalist when it comes to epi. But when I was an undergraduate, I always thought I wanted to go to medical school and be an ER doctor, because I always had this passion for, growing up in where I grew up in Richmond, Virginia, and just seeing sort of folks in our community be impacted by health issues. I wanted to do what I could to kind of help people live as long as possible. And then I realized when I got to school, I went to study abroad for a summer, and actually not really to study abroad, but I went to live in Tanzania for 2.5 months. And I had a chance while I was there to live in a very rural area. They had one hospital that served a lot of people. And a lot of people were poor and lots of folks lived far away. And there was a malaria outbreak while I was there. And this is when I was an undergraduate, so I hadn't taken an epidemiology course. And when I was in college, there wasn't undergraduate programs in public health. Long story short, I got to live through sort of 2 months of an epidemic of malaria in that community, and got to see sort of the real impacts of a community not having a public health system, not having any epidemiologists around to help respond. The hospital had 2 doctors, and those 2 doctors were basically strapped by, they were overrun. They had set up a tent outside to basically admit patients, and folks were living, or patients were on carts and things outside of the hospital. And I realized that the system is one of the most important things that are necessary to be able to keep people healthy, not just the hospital system, but the entire ecosystem of healthcare and public health together. And so then I got excited about public health, and I came back to school and decided I'm going to go to graduate school of public health. And I took my first epidemiology class and fell in love with it, and have been doing it ever since.
And so when you decided to go obviously further to get your PhD, was there a particular area of epidemiology that you were attracted to, or was it more of a general study of different spikes,
Yes.
if you will?
So my dissertation largely focused on chronic diseases. So most of my work in sort of the earlier part of my career really focused on type 1 diabetes and type 2 diabetes, specifically in communities of color. I've always come into public health with a real focus on health equity and understanding sort of differences in communities. Like I said, growing up in my family, just saying my grandmothers, get sick really, really early on in life, and with really complicated diabetes and hypertension, and actually seeing firsthand the impact of those things really motivated me to want to understand how do we get to some of the root causes of those illnesses in our community, to be able to really close some of those gaps. And so most of my focus in graduate school was on chronic disease prevention, and looking at health disparities and chronic disease outcomes.
And we're definitely going to be talking about those healthcare disparities. Now, are you from the Virginia area?
Yeah, I was born and raised in Richmond, Virginia.
Okay, because I see where Lisa shouted out the, what is that, the 804? Yeah. All right, then. So I see you, Rod. I see you, Tanya. I see you, Lisa. If you're just tuning in, chime in, let me know where you're watching us from. So, and of course, if you have questions specifically, make sure that you drop them in the comments so that we can see them as we go along. And so for you, obviously there were certain health issues that you were drawn to based on what you were seeing in your own community. Now, you actually came to Charlotte in the middle of literally when COVID was getting some major legs in Mecklenburg County. How much of a shock was that, given the fact that you were obviously transitioning from one place to the other, but also in the middle of COVID and trying to wrap your arms around that and how we need to handle it?
Yeah, as I think back to the earlier days of COVID, it was pretty bizarre because, we didn't know really what was coming. We didn't know a lot about the virus, how it spread. We didn't know what the impact of it was. We knew that it was some evidence it was more lethal. And so I actually had planned my transition from Philadelphia, where I was their chief epidemiologist and a deputy commissioner in the department. I planned to take 3 weeks off in between. And so I could move to Charlotte and find a place to live and all those kinds of things. Turns out our first plane with patients came into Philadelphia just the week I was supposed to actually leave Philadelphia officially. And so I had to sort of mobilize there because I didn't have a replacement to really help build out the response there for the first few weeks. And so I literally stopped working there on March the 14th and then came here and started on March the 16th. So I was kind of in COVID mode already when I got here. So it was incredibly pretty straightforward for me just kind of to jump right in and get to it.
And so, okay, of course, hindsight is 2020 in terms of where we are now. But what was what did you anticipate as far as how bad you thought it might become versus how bad it actually became?
Yeah, I think, the reality is, we didn't have much to really build our anticipations on. Early days, we were really focused on how do we try to contain this as much as possible based on the limited information that we have. So we issued the stay-at-home orders early on because that is a mechanism we could use to start to slow transmission in the community. I think, any respiratory virus obviously has the potential to spread really, really quickly. So we all knew that it could spread a lot. The biggest worry for us, of course, was how lethal or how fatal it was going to be and how much illness it was going to cause. And certainly the potential, some of our models were indicating that the hospitals could get to a level of strain where people wouldn't be able to get regular care. So we always thought it was going to be a challenge. I definitely think a lot of us thought there might be an end closer to sight than what there really was. Now I think we've sort of accepted that COVID's transition from really being an epidemic in our community to sort of endemic. We expect it's going to cycle over time where we'll probably have these peaks and valleys, these surges over time where COVID cases will rise. We'll see the fall off and we'll see another rise again. Because at this point, globally, we're not on a pathway to eradication, which means that the virus goes away, like polio, for example. We have to have enough vaccine in the globe to basically vaccinate everybody across the whole globe for us to get to that point.
And so let's start with COVID first, because that's where I was getting the majority of the questions before we went live. And so I need you to make this plain, like for people who don't understand like how this virus works as it relates to others, like, because I think everybody gets the idea of what a virus is and how it works. I think everybody in general understands that a virus can mutate. But how is it that this particular, and the fact, Lord, can we just dispel this myth? Coronavirus existed before 2019. Can we make that? Can we start with that first? It existed before then. So let's start with the myths, and then let's get to the facts.
Yeah, I love
that's the first myth.
So the basics of it is it's a virus, right? So coronaviruses as a type of virus have existed for a very long time. That's the reason why folks had Lysol bottles and you saw on the back of the bottle that it worked against coronaviruses. It's a family of viruses. It's not, it's a collection, a group, a type, a structure of virus. It's not this, they're not all the same. Just like you and I, we're both Black, but we're not all the same, right?
Right.
So same concept. So essentially what happens is with this particular strain of coronavirus, every virus, as you've already said, it's just looking for a home. So it's trying to find somebody's body it can go into or some organism it can go into and start to reproduce itself. With the ultimate goal, it wants to take over, but typically viruses are not able to take over. So it goes in, finds a home, tries to start reproducing itself. When it's reproducing itself, think about building a factory. It's like basically copying itself over and over and over again. It has the potential to make mistakes. And sometimes those mistakes that it's making when it's copying itself have a real consequence, and they basically make the next version of it a little bit smarter. Sometimes it doesn't do anything. A lot of time, most of the time, it does nothing. But sometimes it makes it a little bit smarter. And then that's when we start to get into a situation where we may have a variant that has some kind of consequence for how the virus either transmits or how serious it is or how sick it makes people. But typically it's the same type of virus. It just has some slight mutation in its genetic sequence that makes a difference for how smart it is the next time it goes into somebody else. Coronaviruses are interesting, particularly this one, because it has sort of a large genome. So that it's basically it's almost think like a bubble, I guess. Like if you're blowing a bubble, it has sort of a large glow. It's circular in nature. And the bubble, the outside of it is really thin. And so because it's so thin and it has a lot of genetic code that has the potential to essentially make a lot of mistakes. So it has a big genome, it's kind of wide, and so it gives basically more opportunity for it to make mistakes. And the other problem is it replicates really fast. So it does a lot of copying really quickly. So when a person gets exposed, there's a potential for it to obviously make them infectious pretty quickly, but the potential that they will infect people as well. And so because of that, coronavirus, this particular COVID-19 strain of coronaviruses has been a challenge for us to deal with.
And so when we talk about the mutations, what's different is the exterior of it, or the pointy parts, if you will. Is that what is different, or is it the genome itself? My mom would be so proud. My mom's a biology teacher. She's so proud right now. But is it the outside, the spiky parts?
The spike protein, yeah. So if you look at the outside of it, there are some proteins on the outside of it that basically that are sort of spikes. If you see a picture of it, it looks like it's like a globe with a bunch of things outside. So those mutations can cause any kind of consequence. Really, on the mutation difference is in the nucleus of the virus, where it's sort of the program, sort of the computer center of it. So the basic structure still looks the same. It still looks like a coronavirus, but there's some. Again, if you use the human analogy, right, where, you and I are both humans, we're both people, we have slight differences to ourselves, but generally we have arms, we have legs, we have nose and eyes. So it's all sort of the same kind of concept. As the virus is mutating, it's just making a different kind of copy of itself. And sometimes those copies just have become smarter. And the smarter versions of it, again, tend to be more competitive and when you're thinking about how it spreads in a community of people.
And so obviously we all know about the Delta variant. Are there other variants that have already been identified?
Yeah, there's several. And so we actually previously the variants were being classified. Specifically, the ones we look for are the ones that are very unique, that are similar mutations to others that we've seen in other people, and the ones that are doing something different. So the Delta variant, unlike previous variants, so let's take the Alpha variant, is actually a lot more transmissible. So what that means is the virus has gotten a little bit smarter, And so now it has the potential to basically spread more quickly. So it's reproducing faster when a person gets infected, which means they have the ability now to infect more people than they would have previously. And so we've got a number of variants. I think we're up to at least variants of interest, I guess is the best way to put it. The genetics people are keeping a close watch on these and looking for patterns in their surveillance systems that we have for this. There's a Lambda, there's a Mu, and there's obviously, so basically we're going through the Greek alphabet at this point. Previously, variants were being referred to by the country of origin. And that was causing a little bit of unfair discrimination against people because folks were taking that to mean, oh, well, the UK variant means I need to stay away from people from the UK, and that's not really how it works. Because in most cases, because our borders are closed, people are able to move in and out of US and other countries pretty easily. So they started the nomenclature that started at alpha. And so basically there's an alpha, there's a beta, there's a gamma, and delta, epsilon. And then they basically are following them to see how they behave in the community.
So a lot of good questions. So let me get to a couple of them first before we move on to the next piece. So I see you, Franklin, Chris, Lon. I'll definitely Rod, I'll get to your questions in just a second. Let's talk about the vaccine itself, because obviously a lot of people are still vaccine hesitant. Don't really want to touch on that yet, but the big issue that we're seeing in the news today is the booster and what the FDA is going to do, whether or not they're going to approve a booster for emergency use, what that's going to look like. So what looks like a couple of questions are, if you're already vaccinated, will you have, well, Chris asked, if I'm already vaccinated, will I have to get a booster shot in the future? And that's a good question.
Yeah, great question. So boosters are a hot topic, as you said, right now. Currently in the U.S., the only group that's been authorized to receive a third dose or a booster, we're calling it a third dose because it's unclear if it's going to be a routine thing or if this third dose is going to do it. But essentially, the third dose is authorized for individuals who have moderate or severely immunocompromised. So these are folks who have health conditions or are receiving some kind of pharmaceutical treatment or something else that basically has compromised their immune system in a way that it's possible that the earlier doses have started to wane off over time. And so those individuals are now been authorized to receive a third dose. There has been early studies from both from Pfizer and Moderna submitted to the FDA relative to, so essentially the people who were in the clinical trials early on to get the vaccines approved, they've been followed over time. And so they're still checking to see how well their immune system is still primed and ready for a viral infection of COVID. So they're looking at their antibody levels and they're looking to see when they start to wane over time. And so far it does seem like there's some level of waning that starts around the 8th month mark. In the group of folks that they're following as a whole. So it doesn't mean everybody's immune system's different, everybody's body's different, but that's sort of on average is a point where you start to see some decline in immune response. And so they've made a recommendation to the FDA that they go ahead and approve third doses for people, for everybody at the 8-month mark. That is still under consideration at the FDA. They have to make a decision about that. It has not been made final yet. After the FDA makes their decision, then that will have to go to, that's just an approval. That just means it's safe and okay, and it makes sense to do this at the 8-month mark. After they make that stamp of approval, then that goes back to the CDC, and the CDC's advisory committee on immunizations has to review those recommendations. They have to also review the data as well, and they have to review the context at which we're currently living as it relates to vaccines. And they ultimately will make the final recommendation about whether or not we should start giving those third doses for everybody who's gotten it, specifically those people who are over the age of 12 who are currently eligible to receive the mRNA vaccine. So they'll make a decision. So there's still some more steps in the process. We don't expect to have an answer this week fully. There's one more step that has to happen, even if with FDA authorization. And so we'll see what happens. You know, one of the challenges I think is that context piece. We have to recognize that there are a lot of kids who have not yet been made eligible to get vaccinated, who we expect will also be eligible in the next couple of months. Hopefully, fingers crossed, at least our 5 to 11-year-olds will be up next to get vaccinated. And so that data has already been collected and is being reviewed now. And so hopefully that'll be next up. As well as we still have a global, we have deficits in our global supply of vaccines. So as we as a country think about what's happening across the country, you know, there are some countries where older adults that are 75 and older have not yet received a vaccine because it's not available to them. So do we start giving third doses in America, or do we try to help other countries? I think is another important aspect of our global response that we just have to be considerate of.
And that's an excellent point, because that's what we're seeing a lot of the debate on is, okay, we're talking about getting a third dose, and there's countries where people are lining up and can't get dose one, period. Yolanda asked a good question. Are those with certain blood types less likely to be infected by coronavirus? Is that a myth or is that a fact?
You know, I think at this point we don't have definitive evidence that so certainly there's no evidence that there's a difference in likelihood to be infected. There was a couple of studies, I think 1 or 2 studies that suggested there might be individuals with certain blood types who fare better, who don't have as many, the likelihood of severity of illness is not as bad. But
I hear him barking in the back. We're going to keep talking. We on here.
I'm sorry. So there certainly are individual. There's a little bit of evidence that some individuals do a little bit better as it relates to based on blood type, but that's not globally accepted. There's no strong evidence at this point. There haven't been sufficient studies. But in terms of risk of infection, essentially, and in the broad perspective, everyone's at risk for infection. If you can be exposed to someone's droplets when they're talking or in a room with someone and close contact with them, your risk of infection is really driven by those things more than it is about you as an individual. Of course, individuals who are vaccinated are much less likely to be infected and to develop an infection. Because if you think about it, again, the vaccine doesn't stop you from exposure. Like it can't stop you and I from being in a room together and you having COVID. But what it can do is when I breathe in the particles that have the virus in it, my immune system's already got the weapons ready. And so boop, 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 and it shoots them so quickly that I never actually develop an infection. And that's what we always hope for, but it doesn't always happen. And of course, we know people have been infected post-vaccination as well.
And so Roderick asks, as a type 2 diabetic with hypertension, should I get the booster shot or is it too early to tell?
So again, relative to most chronic illnesses are not like type 2 diabetes and hypertension don't automatically mean you have a compromised immune system. Those would not by themselves be indications for a booster shot. When we think about immunocompromised individuals, it's more so like conditions like rheumatoid arthritis, for example, HIV disease, of course. There are other autoimmune conditions like lupus that could potentially be a risk factor, sickle cell disease, where you might expect some immediate diminished impact for your immune system. Then, of course, there are patients like cancer patients who are receiving treatment that impact their immune system, or transplant patients who are on medicines that are already suppressing their immune system. And so all those folks are the typical folks that we think about right now that should go ahead and go in and get their third shot.
Very good. Okay, so if you're just joining us or you didn't catch us at the top of the hour, make sure you drop your questions in the comments. Make sure that, because we can see them, we're going to get to as many questions as we can. And of course, make sure that you like and follow and subscribe and share this broadcast. So, okay, let's get to a couple of let's talk numbers real quick, because there's a lot of questions about, okay, for example, in Mecklenburg County, are we heading towards another shutdown? The numbers don't look good. This is getting bad. Like, what are our trends looking for Mecklenburg County, or at least North Carolina locally? And then how does that compare to what the numbers look like nationally? Yeah,
so definitely for the last several weeks, we've been in, I would say probably 6 to 8 weeks, actually, maybe a little bit longer. We've been in a surge of COVID. We had a really rapid a period where we didn't have a lot of cases, less than 50 cases a day. And then we went through a period of really aggressive acceleration, exponential growth, really, where we were up from 50 cases a day to well over 600, 700 cases every day. A day, yes, per day, new diagnoses per day. And so we are now in a period, we went from having fewer than 100 people, or fewer than 90 people in the hospital with COVID to well over 500 in the hospital. And so that happened in a period of like 2 months over the course of the last couple of months. And we finally have started to see our percent positivity had gotten as low as 1%. And that shot back up as high as 15, 16%. So we're starting to see a plateau, which is really encouraging, where we're no longer seeing the growth. We're starting to just see flat numbers. They're still elevated, but they're flat. And so on average, we're still seeing around 400 to 500 cases a day. And we still have roughly 500 people in the hospital. But certainly we are starting to see that growth that we were experiencing is slowing down. This really started back at July 4th, actually. So we had the holiday, and literally there was right afterwards, there was this huge increase in surge. And we know so much was happening in that time period over the summer. And so that really drove that surge is what drove us to reinstate the mask mandate here locally, because we started to see so much infection and so much spread happening in the community. Unfortunately, what's happening now is we're starting to see the lagging indicators. So we still have people in the hospital. We have a lot of patients on ventilators. We heard from the hospitals this morning that the majority of the people in the intensive care unit with COVID are on ventilators, which means they're really, really sick, which is really unfortunate. And unfortunately, the common thread between more than 92, 94% of those folks is they have not yet been vaccinated, particularly among the young people. So it's something disheartening. The other important number that we're starting to see really accelerate are deaths. And so what happens typically, at least a few weeks after you start to plateau, you start to see really all the deaths of folks who got sick during the peak of the infection, but weren't able to fight it off in the hospital. And so we're starting to see a lot of that. So for example, today, I believe we had 12 deaths alone just today here in Mecklenburg County. And a number of those folks were young people. And when I say young people, I mean folks in their 20s and 30s and 40s, 50s. And it is certainly disheartening. And I can tell you that the overwhelming majority of them, as a matter of fact, all but one were not vaccinated at all.
And so what are the trends nationally? Because obviously we hear that, Texas is a hotspot, Florida is a hotspot. Yeah. There's other places that are hotspots, but we're seeing we're not hearing a lot about it, but the numbers as it relates to young people, meaning kids, having the issues and the complications.
Yeah, so the same thing's happening nationally. We had gone a period of really high acceleration, and we're starting to hit a plateau now. So which, of course, is certainly encouraging. We are seeing a lot more infections among young people, not just children, but a lot of infections among young adults. They've always overrepresented in terms of folks who are infected. They're the ones who are more likely to be out and about and not as worried about COVID as other people. But certainly, we saw a lot more infections on the young children and the teenager population. Much more than we saw previously. And again, that goes back to a lot of stuff that we had stopped doing. We got back to doing. Summer camps are reopening. Kids were playing sports over the summer. Lots of activities happening, vacations, a lot of travel going on. And so kids and families started to get infected at much higher rates. And so we have seen more young people, more kids. But the population that's most vaccinated in Mecklenburg County, our older adults, are largely underrepresented in the case counts. So there are much fewer cases among older adults. Of course, they're also more likely to comply with mitigation measures and adhere to those things that we keep encouraging folks to do, because, of course, they've experienced the most loss. If you look at still overall what's happening in the county, our older adults are the ones who've lost in terms of loss of life and have folks who have long-term complications. And so certainly that's what we are.
So, for example, like when we talk about the myths and the facts regarding the vaccine and the booster, and when we were on the show before, we had long haulers who had various issues as far as health in their lungs. And I had a really interesting conversation with my sister, who's a nurse, and she had shown me a picture of the difference between a regular lung and a COVID lung, and it was disturbing. I was like, wait, what? So, you see a regular lung, you can see the black, and COVID lung, it was like a big white blob. Yeah. So, for people who've had particularly, and I know people personally within the last couple of weeks who were unvaccinated around my age that had it and had some had major complications. Hopefully that won't be one of them. But what are some of the common myths and facts that you are finding about the vaccine? Really, let me ask it different. What's the craziest thing you've heard when you're talking to people when they're asking you questions that you don't want to be like, are you serious? But seriously, I mean, there's a lot of misinformation out there, but what's the craziest things that you've heard?
I don't even want to repeat most of it. It's
you
you know,
got to. It's fine. It's fine.
I mean, some of the stuff that the common things that people have heard, it makes you magnetic. You've seen the thing on TikTok where people put their arm up. I've heard someone told me the other day that it's gene therapy and it's going to alter their body's genes, and like your body's genome, and it won't. It will teach your body how to recognize and fight the virus and produce antibodies for the virus. I mean, there's all kinds of really conspiracy theories really about the development and the generation of the vaccines, that, it's some government conspiracy. And it really, that stuff is really unfortunate because those things really make people feel unsafe and uncomfortable and not trust. And so we keep forging ahead, trying to make sure we talk to people, answer questions. We have teams out trying to clarify some of the information that they've heard. And we try to be as responsive as possible. There's a lot of questions about how quickly they were developed, and the reality is the science behind the vaccines has been under development for decades and been used in other settings before. Our genetics people are so smart nowadays. Like, if anybody's been watching what's happening with genetics, people can actually sequence a person's genome, and right. So being able to identify this virus, say what it was, and be able to find a resolution for it really is a remarkable sign of how well DNA actually works here, and how well science, how far science has come in the world and in the U.S. in particular. We've heard all kinds of stuff about there's a chip inside of the vial.
Is that even possible?
No, I mean, if you sit back for 30 seconds and think about it, and you've ever looked in the vial, first off, it's a largely clear solution, and there's absolutely no way. If there were one chip in there, how would I know whose chip I put in whose arm? Like, it doesn't make sense. Like,
right.
Logically speaking, it's not like we're sitting there programming the needle to say this shot is about to go in Yolanda Trotman's arm, and this chip is in your. I mean, it's virtually impossible. And the first and the second dose are the same. It comes from the same vial. It's the same amount of vaccine. All of it's the same, and they all come from different lots. So the idea that there's a chip inside really doesn't make a lot of sense, like legitimate sense. Then there are other concerns that I think are legitimate, right? People are concerned about if I'm pregnant, does it make a difference? If I'm breastfeeding, does that make a difference? Or if is it going to have some impact on my ability to become pregnant or to even to get someone pregnant? And so I think those concerns are legitimate. And again, the science is clear that there's not a risk. There seems to be no clear risk between any kind of vaccine adverse events relative to pregnancy, sterility, or fertility among men or women. And again, yes, it is new. And so in full disclosure, they're still learning. People are tracking on a daily basis any adverse event among people who've been vaccinated. But what happens so often is that people are quick to make this cause and effect relationship that just simply doesn't exist. So people already get sick. People have heart conditions. People have miscarriages, for example, not to be too morbid, but these things happen every single day. And so everybody's getting vaccinated right now. So if somebody happens to have one of those unfortunate health events after or near the time they had the vaccine, everybody automatically tries to say, why did that happen? And they try to say the why is the vaccine. No different than somebody ups and gets sick one day. People say, well, why me? What happened, right? What did I do that led to this to be the case? And the vaccine becomes a very easy scapegoat when that's the thing people are focused on, especially in an environment where it's been so heavily politicized and it's new. So we just have to be careful before we start making these associations. People have heart attacks every day, unexpectedly. Yeah, I'm sure anybody that's listening to this has knows someone who had an unexpected heart attack, a stroke, or some health condition that would happen. That nothing happened specifically prior to that we could blame it on, right?
Right.
But because the vaccine's there, it's an easy option to say it's the vaccine's fault that killed, my relative or loved one. And it's not being insensitive, but we just have to be careful about cause and effect.
Okay, I'm gonna take a couple more questions on this and move on, but you still haven't told me the craziest thing that you've heard somebody say about the vaccine or the Rona. Come on, now I know you got to have a really good one.
Let me think. Most of the craziness, I'm trying to think. I really haven't. I mean, those are really the most common things we hear. I'm trying to think back to 6 months ago, and so much happened since then. We did have a couple of doozies, one session we were having, but honestly I can't remember. I'm not even gonna lie.
Okay.
Oh.
Okay. All right. So you have so here's your task. You have literally 1 minute. How do you convince somebody who is still not vaccinated to finally just get the vaccine? And go.
So, I will tell folks every day, I fully understand people that are concerned. This is hard to do because typically I try to understand and hear people, because I recognize everybody's reason or thoughts or what's going on with them is very different. Like, people have different beliefs. They feel differently about it. And so it's important for me, particularly not just as a healthcare person, or a public health person, but just as a person to hear people. What is it that's keeping you? And what part of that can I talk to you about? But the reality is that at some point we as a community, especially the Black community, we've got to move over. We've got to start to move toward this point of away from resistance and hesitancy to getting the vaccine, because it is truly the right thing to do, unless you have some medical reason not to. And the only medical reason is that you're allergic to it, to some component of it. And in that case, there's another option. But the reality is, a lot of the young people that I talked about earlier that I got reports of their death today were young Black people. I mean, in their 30s and 20s, individuals who don't have any severe underlying health conditions, probably thought they didn't need the vaccine, because I heard somebody tell me last week, I don't need it. Everybody else is getting it. I'm okay. But the reality is, you never know how your body's going to respond to an infection. And if it's preventable. The vaccine is a tool that helps us to be able to really move beyond this pandemic as a community, but also lowers the risk of you ended up with any severe outcomes from it.
Well, that was 1 minute and 37 seconds, but that's good. That's good. All right,
qualifier on there at the beginning. All
right, we got 2 more quick questions. Chris asked another good question. Do you realistically see or expect our country to become 80 to 90% vaccinated, or at least get us to herd immunity, which is what, 70% or 75%?
Yeah, it's interesting. The herd immunity doesn't have a definitive threshold. Really, it also depends on what's happening with the virus and variants. I personally believe, and I'm getting to the point where I feel pretty strongly about this, is that we're getting to a point where, like I said earlier, COVID's going to cycle in our community, similar to the flu. Because they're going to continue to be variants. Not even if we all got vaccinated in America, what that does is that protects us from having the impact of the virus. People will stop dying. We'll stop having severe outbreaks. We will really move to a place where it becomes like the common cold or the flu in our community. And that is what we're trying to accomplish. That's step number 1. Step 2 is getting rid of COVID completely. But we got to get to step 1, and we're having trouble getting there because folks aren't rolling up their sleeve just yet to get vaccinated. I do think we'll get there at some point. I think I've talked to people, our vaccination rates are up right now, and we're still having these conversations. I just was talking to a young brother last week, and I sat and talked to him for 90 minutes, 90 minutes straight about the vaccine. And he called me at work at 3:30 last Friday and said, "You know what? I just got my first shot." And if that's what it takes, we'll keep doing that. But that's going to take us a little bit of time. So we're going to keep going, and we'll keep doing that. But of course, with us only having less than 40% of the Black community vaccinated, we've got a long ways to go. We still got to get kids vaccinated. And then after the 5 to 11-year-olds, we'll be down to the 6-month and to the 5 to 5-year-old group. And then once we get to that point, the real hope is that, we will learn to live with COVID. It's going to be here until we get on the pathway eradication. Because like I said, other communities are not at a point of vaccination or close to that. We're doing good as a country compared to some other countries, particularly those that are not as westernized or developed. And so we got a ways to go. And so, again, I used the term endemic earlier, which is another one of our epidemiology terms. And that just basically means a virus is sort of commonplace or is at a steady state in a community. And we're really transitioning more to that than we are to looking at sort of a global pandemic.
Yeah, that was definitely a great question, Chris. All right, so if you're just joining us, we're going to switch gears for the last 15 minutes or so, because there's a couple of other areas I want to make sure that we touch on. Because it's so important, because we talked so much about COVID. There's so many other issues that are out there. So if you still have questions, you can still have time to drop them in the comments. But what do you see? And I want you to speak on this generally, but more specific to the Black community. What do you see as being probably one of the biggest health challenges that men face? I know there's a lot, But what would you say? I wasn't saying that to be shady to the men. Let me qualify that. I wasn't being shady. I'm just saying, what are you seeing as the biggest health challenges that men are facing now?
Yeah, I mean, there certainly, as a community, I would say both men and women, and I'm doing this intentionally because it really is a community challenge. It's not so much a gender-based challenge. It's much more what's happening in the Black community for us. I think one of the most important, or two of the most important factors that are leading to, so if you think about, the way I think about this is what's causing people to die early, right? So, at some point, everybody lives and you have to die from something. And typically the end result is some form of cardiovascular disease or heart disease, because at some point the heart starts to give out over time. But if I think about what's causing us to really sort of die early, I think one of the most important health conditions that we've got to raise awareness about and do something about quickly is hypertension. And hypertension, and I say that because it really is one of the very first indicators that something is wrong with our health, that something's wrong with the way we're living. Either we're smoking too much, drinking too much, not exercising enough, or not eating the right foods that start to raise or incrementally increase our blood pressure over time. And so hypertension is really, it's like the first red flag. And it's a red flag, but it's a quiet flag. So if you don't get your blood pressure checked, or you're not having conversations with your doctor about it, or making sure you're actually getting a physical every year to see what's going on with my blood pressure, it is one clear indication of what's happening. It's a red flag or precursor for strokes. A lot of folks have hypertension that hasn't been diagnosed, and they up and have a stroke one day because they haven't got their hypertension diagnosed, and then it hasn't been treated. And so then that causes a blood vessel to burst. That unfortunately happened to my father. In addition to hypertension, I think connected to that, of course, is our just general well-being as it relates to weight management. Because certainly obesity is another one of those indicators that contributes to hypertension. And it really contributes not just to hypertension, but other chronic illnesses like diabetes and other.
Right.
Make a difference.
He said, yeah, y'all better get your blood pressure checked. Okay, anyway.
Yes. So I think blood pressure. I think blood pressure is certainly. I think blood pressure is certainly.
We lost you.
Oh, sorry. I think blood pressure is certainly important as we think about sort of what I want someone to take away from this. What are things I need to be thinking about? So weight and blood pressure are really important, and I think those are things that we gotta keep an eye on.
What about for women?
I think the same is also true, but I also recognize that, and particularly in the Black community, when it comes to those conditions are much more critical, or much more. It's much more urgent because they're also impacting our reproductive abilities or capabilities, or what our outcomes. So oftentimes women who are having complicated pregnancies or complications with pregnancy before and after, a lot of time it's driven by either being overweight prior to pregnancy, during pregnancy, or having hypertension issues during pregnancy that ultimately results in some complications during the point of pregnancy, which has created really clear disparities, not just in the maternal outcomes, but also in the child outcomes. So we have more preterm births in the Black community as a result of individuals who are having complications during pregnancy. And that starts a life cycle of health challenges, because babies who are born prematurely, of course, are disadvantaged in many ways because they have challenges up front. I mean, their development, they're out the womb too early, and oftentimes or sometimes are faced with developmental challenges. And so I think for us as Black women, it's really important to make sure that those we know our numbers. It's one of the campaigns that will probably be coming out of this health department soon, but we had in Philly. It was really important for us as a community to know our numbers.
And so for men and women, well, let me go back to the men, for example, particularly men that are catching this live or they're catching the replay. Prostate health is also a big issue. Not really seeing it so much in the news, but how do you convince men specifically that they do what's necessary to get their prostates checked so that they don't have issues, not just necessarily with prostate cancer, but other issues associated with that as well?
Absolutely. I mean, I think cancer is certainly an area where we've definitely got to do more awareness, and in every community, not just in the Black community. As it relates to prostate in particular, I definitely think there are intervals. One of the things we as a community have to do is really start to adapt physicals as a part of our routine. I think, we file taxes every year. We do a whole bunch of stuff on a regular basis. And I feel like, having a primary care doctor has got to be one of those essential things that everybody does. And I think that is where, for us in public health, we start with addressing many of the underlying health issues that either go undiagnosed, untreated over time. It's going in to see a primary care physician when nothing is wrong, when you don't feel bad, when you don't feel like something's going on, just going to see a primary care doctor to get your numbers checked, to know what your blood pressure is, your cholesterol is, what your weight is, to understand sort of how you're doing physically. And then your doctor will be able to say, okay, you just turned 50. It's time to get your prostate levels checked. So we know, in fact, how things are going. And then you have a baseline. And those baselines are a lot of the way that physicians are able to make decisions about how things are going and how they're not going. So knowing your numbers, I think, is really, really important for us if we want, as a community, to really sort of improve our health over time. And I think we all know sort of there are some basic things, having a primary care doctor, not smoking cigarettes, being physically active, eating a balanced diet. Those basic sort of 4 or 5 things on our checklist is really managing our stress, our mental health and mental well-being are really important things. Just those 5 things alone, if we all just sort of made ourselves like an annual checklist of here's my health wellness for the year. Like I'm gonna go to physical, so I know my numbers. I'm gonna be intentional about being physically active. I'm gonna work on a balanced diet, and I'm gonna focus in on trying to manage my stress on a daily basis, and balancing my life so I'm able to do that. I think we'll make a lot of progress.
And so how do we effectively advocate for our own health and the health of others? Because this comes up a lot when you're talking to a doctor who's got 15, 20 yes. patients that are scheduled at 10-minute intervals and they got to bill. It's taken away from that care and concern that a lot of us feel that we used to have back in the day, where you could shoot the breeze with your doctor.
I hear you. And I think the reality of it is that patients have a choice, right? So, one of the challenges we have is that we still, as a community, as a state, we have not expanded Medicaid, and so there are a lot of folks who still don't have insurance in this community because they can't afford it. And so that's definitely a challenge. And so we have limited options for folks who don't have insurance or primary care, but we do have more providers who are providing care to folks who don't have insurance. And we're working as a county to try to expand access as much as possible for people who can't afford to pay for healthcare insurance. But we still have to fight for insurance because that's a very important key. Healthcare coverage is really important for all of us to be able to make the case. So advocacy for that for us as a community is important. As an individual, I think you have a choice, right? So you need to find a physician or a doctor who provides the level of care that you want and expect. Because remember, they're getting paid. You're a customer. You may not be paying them, but you are a paying customer. So if you treat the doctor just like you treat the server at the restaurant when they don't bring out your food hot, and expect or demand or ask for a certain level of service or take your business elsewhere, then certainly that's what you have the right as a patient to do. Because your insurance company, you might not pay them, but they are going to get paid for that service. And we're working. Our job, one of our key responsibilities is to work with providers to make sure that they are providing a healthy medical home for patients in this community, regardless of whether or not you can afford 5-star or Cadillac concierge service or not. We should have, everybody, I believe, should have access to high quality 5-star care.
And we cannot stress that enough within our own communities, especially for our elders and all of that, making sure that a person is not just kind of pushed through and not have those conversations, and to be able to talk plain and to explain what's going on with the person. Not just say your LDL is high. What does that mean? You got to be able to explain those basic things.
Yeah, and one of the and I should say this to be clear, one of the basic tools you can use is asking questions. If something doesn't make sense, don't just nod your head and say, okay. It's okay to be stupid with the doctor. Like, it is absolutely okay to go to your doctor and have no clue what they're talking about and be like, I'm just plain, this doesn't make sense to me. And ask those questions. And if they're rushing out of the room, keep asking questions until you get the answers that you need. And they can't pick you up and let you out. You say, I have questions. I want to be able to understand. This is a drug that's called, hydrochlorothiazide. What does it do? Like, what is it doing to me? How do I understand it? I think it's fair for folks to understand that they have a right to ask questions. They have a right to understand what treatments they're taking. They have a right to understand the status of their health. And more people just have to ask questions. And then we've got to be good humans, right? We've got to be good neighbors. there's some people who need our help to be able to do that. And so more of us have to step up and help those in our community, our family, our aunts, uncles, grandmas, and even cousins and brothers, if you need to help them come along with those of us who are able to navigate those systems a little bit more easy. We still got work to do on the systems. I think definitely there's systemic work that has to happen to make healthcare more easy to access and more easy to navigate, and make it more, touchable for people who don't understand science. And so we have work to do there from a systems perspective. But in the meantime, we certainly can help each other.
And so usually the topic that most people don't want to talk about are sexually transmitted diseases, what the numbers are looking like, particularly in our community, what's going on with HIV. There was talk something about, is there a vaccine coming? But we still have to have those conversations in our community. We can't just because we're not hearing about it on the news assume that we're okay.
Absolutely, we're not. You're going to be hearing a lot more about that in the coming weeks and months from the health department as we really work to recenter the narrative around health in this community. COVID is certainly a threat. It's having a huge impact. It's gone from not existing to being the third leading cause of death, which is almost unheard of.
Oh my God! Say that again.
It's the third leading. In 2020, it was the third leading cause of death. So it went from not existing to the top of the list in Mecklenburg County.
Wow.
So it's cancer, heart disease, and COVID. So when you think about it, that's why there's so much emphasis and focus on it. And it's kind of real, right? And when you think about, it killed so many people last year that it equated to that level of importance in terms of the list. But there are a lot of other issues that's continuing to plague our community, particularly as it relates to STIs. We still continue to see increase in all of them. Gonorrhea, chlamydia, syphilis, HIV is still here. And so we've got to be careful, especially those things that we can prevent. There's a solution or resolution for all of those things. There's options out there. We got options at the health department, whether it be PrEP or condoms or whatever you might need to be able to help folks prevent the spread of those infectious illnesses. We've got work to do there too. Folks, a lot of especially among our younger people, are becoming too complacent with pharmaceutical treatments. Oh, it's okay. I'll just get a treatment, because it's treatable, and I'll get a shot or I'll take a pill, and that's not okay. There could be long-term consequences. Where obviously, there are other viruses and illnesses that you can't just take a pill for that could be transmitted the same way, and so we've got to really continue to work in that space as well.
And so for people who don't know or didn't catch this at the top of the show, you are going to be the incoming Director of Public Health for Mecklenburg County, the largest county in the state. I know we're in the top 50 nationwide. Are you our first African-American public health director?
I am, yep.
That's what I thought. Okay, well, take a moment. Yes to that.
The health department was established like 117 years ago, and has not yet to have a person of color in leadership.
And that's incredible. That's incredible. So throw some hand claps in the comments, okay? Okay, but that being said, because you began January 1, is that right?
Yes.
Officially?
Well, December 1, but yep.
Okay, and so what is your vision? What is your vision in terms of what things do you want to tackle beyond COVID? And what is your vision in terms of tackling some of the healthcare disparities that you've seen since you've been here?
Yeah, so the health department is a large operation. We have so many various areas and aspects of it. So there are a number of areas where I've been really focused specifically on our operation. We have well over 900 employees that work for us that do a lot of different work that a lot of folks don't even know about, a lot of stuff that we do. But first and foremost, of course, I want us to be a top-notch service provider. I really want us to make sure that the services that we provide to those in our community, both our customers, our clients, our patients, are 5-star. Just because folks are even receiving healthcare at the health department doesn't mean that it shouldn't be a 5-star experience. And so we want to make sure our operation is providing that for people in our community. Secondly, I am laser focused on making sure that we are using data and information to drive our decision making and to help us to make the best decisions about how we invest resources, both people and money. As an epidemiologist, I feel like data not just is able to tell us what's happening, but it's able to drive our decision making and drive what's.
Oh, okay, y'all. Wait a minute, we lost him. Hold on a second, everybody, stand by. Hold on. So I'm going to give him a sec to pop back on. Not, his dog probably ripped out the internet and said that's enough. But as I said before at the top of the show, if you have not already done so, make sure that you share this stream, and make sure that you share this stream, and obviously make sure, if you haven't already done so, make sure that you like, follow, and subscribe. He's getting ready to pop back on in just a second. And as I said before, we still have time for a couple more questions. If you have any more questions for Dr. Washington, we'll be able to answer those questions as well. The other thing is that our next series, actually, that I'm working on a 2-part series. So the first one is going to be about Lady Legends. It's going to be Lady Legends in both the areas of R&B, hip hop, some names you haven't heard from in a long time. And I'm excited to have conversations with them. And I'm bringing back Wonderful Wednesdays, where we're going to be highlighting people who are doing amazing things here in Mecklenburg County. Looks like Dr. Washington's dog has released him and allowed him to come back. So we got him back. I'm telling you, that's what happened, y'all. The dog was like, I'm about to yank out this Ethernet cord. And that's that. Okay, we got you back.
It's like when the clock hit 9. It's like I feel like Cinderella at the ball. It's like the clock hit 9. You're out of here.
Dog was like, I'm taking this cord. We're done. I'm hungry.
Yeah,
you don't have my snack.
He's probably shut up. I'm so glad that you are bearing with me tonight. Anyway, I was giving you a 3-part answer. So the first 2 parts were about our service and the data using to drive a decision. But I think most importantly for me, we've got to do everything possible to protect the health of this community from all things that are health consequences. But also, we've got to close the health gap. We have a huge health gap in this community and big cities across this country, in this country globally. And so my life work is really committed on to how do we not just improve health for all of Mecklenburg County, but how do we close the gap, right? Where we know there are clear gaps in health outcomes. People are living longer, people are living shorter. How do we close those gaps? And a lot of that starts with really building communities that make good health easy for everybody to achieve. And so being healthy should be the easiest option, and we've got to figure out how to systemically make that the easy option for everybody, not just those of us that can afford to shop at Whole Foods, but those of us that and have health insurance, but for everybody. And so that's really sort of my goal and focus.
And so will that address issues dealing with food deserts and food insecurity that we're seeing? Because
exactly.
That seems to be a huge issue. And for people who don't know or hadn't heard that term, what does that mean?
Yeah, so food insecurity is essentially folks who are, we have thousands of people in the city who every day have to worry about where their next meal is going to come from, or don't have the security of knowing food is not something I have to worry about. And those individuals oftentimes access food through food pantries, through other kinds of ways, or don't have any means to access food. We also have, and that's the food insecure, we have neighborhoods that are food deserts, meaning that there are not places in a community within a reasonable distance of travel, either from public transit, walking, or I can go and get fresh groceries. The only options in some neighborhoods is McDonald's and Burger King and Taco Bell. So if we go back to earlier when I was talking about how people, their blood pressure, their salt intake, and how their body mass index, being in an area, being in a neighborhood or community where all you have in that community is the junk I just described, then that's all. Those are your options, right? There's no grocery store that has a produce section that has a salad or has fresh produce or fresh meat or fresh anything that you can access. A lot of processed foods or just corner stores, and so those are, to me, deserts where there's stuff there, but it's not the stuff that you want. And so that certainly is a challenge. And again, that goes to some neighborhoods. It's not safe for kids to use the park to go exercise. The basketball court isn't a safe place, right? And so making it a safe place helps people be able to socialize, exercise, and address those 5 things I talked about earlier. How do you live active? How do you balance your mental stress and well-being? And so making every community have access to those things that, again, make it easy for us to achieve good health. Is what we've got to work toward as a community and as a society in terms of equity.
Well, but how do you have that conversation with people who don't have that issue? What I mean by that, how do you have that conversation with people who don't worry about that, who can shop wherever they want to go, who have a car, who can do whatever? That doesn't resonate something that's important to them or directly affects them. How do you have that conversation to build that support when it doesn't affect that person directly?
Yeah, so the one of the most critical ways is back to my number two sort of focus is showing people. One of the things that we spent a lot of time doing in Philly as an epidemiologist was how do I tell the story of our communities using data in a way that compels people who don't live in a neighborhood to care about it, right? How do I tell the story of the west side of Charlotte, right? How do I show numerically the implications, the impact, and what is it that's happening in this neighborhood, and how do I show how different that is to another community, and how do I show the impact of that on people's health, right? So how can I line up food access with quality of schools, with the ultimate life expectancy for a neighborhood to show the multifaceted sort of like drivers of life in the community? And then how do I tell that story to politicians, to elected officials, to business owners, to corporations, to healthcare systems, to those folks who hold the keys in society and hold the purse strings? How do you make the case to them that it's worth the investment to really target those neighborhoods? And then you align those same issues I just described with all the other things you see, the median income of that neighborhood, right? Like if you look at where certain types of food establishments are located, I can guarantee you'll quickly see that there's not certain types of food establishments located in certain zip codes where the income is average a certain amount.
It's like Trinavia says, food swamps.
Yeah, they won't go there, right? Like you won't get Del Frisco's to set up in the hood, right? It's not
right. Let's keep it real.
It's like just being honest. Like you don't see Whole Foods in certain neighborhoods, right? So how do you make the case to compel people, and then how do we make strategic investments as a government entity to also make sure that those that it's not just an economic decision, that we're able to make decisions with an equity lens. And I'm very appreciative to the county board and to our county leadership, our county manager, for their commitment to making sure that we keep an equity lens on the work that we're doing and how we make investments, because that's so critically important. Because to your point, Yolanda, everybody has to care, right? It has to be an everybody problem, not just the folks who live in those circumstances. And you really have to show people. And if you can't get everybody out of their office rooms and from behind their Zoom screens and take them to the neighborhood, then you have to figure out how to compel them in a report or an information in a way that they can receive it.
So the last topic I want to touch on briefly, and actually it's a great segue because Franklin asked, are there any initiatives that target the mental health disparity, especially as we think about this in terms of young people's suicide rates increasing? I'm sure everybody has had some sort of issue during COVID if you're human. Everybody's gone through some level of depression, some level of anxiety, all of those things. So what are the initiatives that you envision in terms of dealing with mental health in general and the disparity in terms of access for people of color?
Yeah. So one of the important things I think is as a health department, at least our role is really to focus in on sort of the access issue. How do we tell the story of where are there mental health providers, where are they available, where they're not available, and what are the impacts of people not being able to access the services that are needed, so that people to drive the healthcare system to really respond and drive policymakers to respond as well. I think we have some new innovative initiatives around mental health that I'm really excited about. You probably have heard about the behavioral health urgent care that we will hopefully be building pretty soon, which really is an opportunity for people who are experiencing mild to moderate mental health situations. Mild to moderate acuity mental health situations. They need to go someplace that's not home to get some immediate care that's not the emergency department, or not to the mental health hospital, but they need immediate care. Creating that as a resource is certainly something I'm excited about that we'll be doing in the near future. Also, we've launched, the county has a MedCope program, which really is us trying to provide access to behavioral health services and treatments and therapies, addiction counseling, addiction services, and rehab for everybody. So whether you have insurance or don't have insurance, and we're working now to really try to align that to really sort of make those long-term, some of those investments or some of those initiatives were launched specifically because of COVID. And so our team, along with our Consolidated Health and Human Services Agency, are really working now to figure out how to make sure we're aligning all those initiatives for long-term impact here in Mecklenburg County. And so I'm hopeful and excited that those MedCope is going to grow and become a part of how we make sure people who need mental health services are able to access them. And you probably know also, big picture of the policy, from a policy perspective, the county has engaged a new provider, a managed care provider for our mental health services. And so we're hopeful and looking forward to that relationship with Alliance and seeing how that, looking for positive impact in the community as a result of that.
Fabulous. So thank you, Dr. Washington,
My
for
pleasure.
taking your time out this evening. There were a couple of other questions that I saw that popped up that I won't be able to get to tonight, but we always have time for you. We always have time for you, even if it's a mini combo, because it's so incredibly important that we have these conversations and we get the information out there. I think you muted, but that we have people out there and we get people the information that they need. So are there a couple of, now how do people get in touch with, I think you are muted, there we go. How do people get in touch with the health department directly? Is there a main number that people can call if they have services that they need?
Yeah, specifically if you have COVID related stuff, you can definitely contact 980-34. I haven't said this number in a little bit of time, so I'm gonna make sure I got it right before I mess it up. 980-314-9400.
Okay.
That is the number for our COVID hotline. That number is 980-314-9400. So if you have any questions, you can always reach us there. If you just have questions about, COVID testing or where to go get tested, you can also call that number. If you have questions about the vaccine, how it works, or more questions, or want us to come to your house and give it to you, call that number. Everything is available there for COVID. And then generally speaking, the health department's website is on the mecnc.gov website. You can feel free to look there for services and resources. And we're always happy to be a resource to everybody.
Well, listen, I think I speak for everyone who has ever met you. Watching this tonight or will catch the replay, we are really, really excited to have you come in as the Director of Public Health. You obviously have a very strong and broad vision. And of course, not to take away from any previous public health directors, let me be clear, but it's nice to be able to see your openness in terms of being able to not just talk plain, but also have courageous leadership, which we don't always find in this space. So thank you so much for joining us. For those of you who caught this at some point during the episode, definitely go back and catch the replay, which will be live. Will be up live rather, just as soon as we finish this broadcast. Make sure you share it, especially as it relates to the segment that we did on COVID at the top of the show. Of course, if you haven't already done so, make sure that you like, follow, and subscribe to all things at the Convo Pod Show. When Dr. Washington's dog said, "Nah, we're done." What I did say when you were off is that the next series is Legendary Ladies, where I'm having some artists of names that you haven't heard from in a while. We'll be doing a personal conversation series with them. If you haven't already done so, definitely check out the website because all the previous show episodes are up there as well. Of course, again, if you haven't already done so, make sure that you subscribe to the YouTube channel at The Conversation with Yolanda Trotman, and as well make sure that you like, follow, and subscribe at the Convo Pod Show. I did put it in the comments as far as the COVID hotline. If you have questions, because we spent a lot of time on that at the top of the episode, 980-314-9400, at least for those of you who are watching locally in Mecklenburg County. That's where you can get your questions answered, where you can get a vaccine, where you can get tested, all that. You said people come to your house and give you the shot.
Yeah, we have a homebound program and we have a doses to door. So
get out of here. So okay, well anyway, yeah, they'll come to your house. Who knew? But in all seriousness, if you've not been vaccinated, please consider that. Me personally, knowing people who have gotten it recently and what the challenges that they have faced, the science is the science. It's for those of you who are waiting on it to be FDA approved, you've got that. And the numbers don't lie. If you didn't catch that part, we talked about the numbers, just the number of people who passed away today, all younger people, and all but one, as Dr. Washington said, were all unvaccinated. And so please take this very seriously. Wear your mask, get vaccinated. Anything else, doctor, that you want to chime in on before we wrap it up?
No, just thank you so much for doing this. In a world where there's so much misinformation on social media and on media platforms, as much of this as we can do, I'm welcome to, happy to come anytime I can to make sure we're combating the misinformation that's out there.
So yes, schedule your mammogram, schedule your physical, wrap it up, mask it up, and we've got to do what we have to do. Get educated. Don't be afraid to separate those facts from those myths and speak truth to power, because the truth is the only way that we're going to deal with some of these issues especially as we wrap our arms around the issues that are distinctly affecting our community, and ask questions. That's probably one of the biggest takeaways tonight, y'all. When you go see your doctor, your PA, your nurse, or whomever, make sure, I'm getting an echo, make sure that you definitely make sure that you speak to your provider and don't be afraid to ask questions. That's super critical. So we will see you all in 2 weeks for the next episode. Definitely tune in. It's going to be a very, very interesting show, very inspirational. So again, Dr. Washington, thank you again. Go feed the pooch, give him some treats or something, because he's about to turn this mother out if you didn't get off of this.
He's sitting there like an angel now.
And what if y'all didn't catch it, you know I'm about to call you out at the very beginning. I said, you sure ain't nobody's gonna be running through the house? Oh, my dog is here. Well, he's not gonna say a word. Yeah, okay. I guess he told you. Everybody.
He's only 1 year old, so I give him a pass.
Oh, that's all right. That's all right. He gets a treat. But tell him don't do that again next time. All right. Y'all have a good night. Make sure you like, follow, and subscribe. Take care of yourself and each other. Make sure you share this episode. Night, everyone.